Good evening, Dr. Libby. We have your patient Joseph here. So what I did, I pulled up most of the data that we collected or that you collected. So I'll start with the photos. And I put your treatment analysis and your workup on the left side. So we'll work off both of these. So let's start with moderate to severe bone loss, periodontal disease. I would imagine that's true based upon the spacing that he has. If we look at his PAs, how do we define periodontal disease? Horizontal or vertical bone loss. We don't have any vertical bone loss here, at least not in this image. Is this horizontal bone loss? It's a little tough to say where this image is foreshortened slightly, but it doesn't look like he's lost that much, if any. Let's look at the bite wings. Yeah, definitely some tartar buildup, but I wouldn't say this is a full-blown perio case, but more something that requires some basic SRPs. But I'm sure you and the hygienist have either already done this or discussed this with the patient. But we should see some success coming out of this case. So definitely not a case we need to refer to the periodontist. When we need to, we should. And this is not one of those times. Dental abscesses. You had mentioned in the email, I believe it was number 11 or 12, you had said that does look suspicious. So let's look at our friend, the CAT scan. So here we are. If we look from the axial view, I would definitely agree there's some shadow there, but it doesn't seem like an abscess. It doesn't seem like it's associated with the root. It's more spaces within the bone, almost like those air spaces that came on that documentary, The Root Cause, that make people go crazy. If you haven't seen that documentary, it's worth a watch to see what patients might think about our profession. But I would test that, but the vitality there, I bet that's vital. If not, then we can talk a little bit more about it. But I would leave it as is for now. Significant decay. Yes, if we look at the photos, we could see some decay pretty much throughout. Looks like he lost a cusp there. There on 19. That's an interesting premolar. So large old restorations, we always want to let patients know that restorations of this kind are likely to cause a problem that requires the removal of a tooth, whereas if we restore it, we remove that from being a likely possibility. But these are terms you already know. Asymmetry and head tilt. We like looking at the musculoskeletal structure. We know that the muscles of the head and neck and the jaw are connected to the head or the muscles of the rest of the body. Potential airway issue. He did have snoring on his med history. Let's bring that up real quick. So he circled snoring, acid reflux. If you see a guy with an 18-inch neck, acid reflux, snoring, and some parafunction, definitely somebody likely to have sleep apnea. So we will put him through our sleep apnea program and let Ray tease that out. I would have Ray do that before you do any treatment. Reason being, if we want to set his case up where his mandible is slightly down and forward to open up the airway, then we want to know that information ahead of time. Obviously, if his joints are stable. But we can talk about that once we get to the solution stage. Gum disease, severe wear, entrapment. The lower jaw trap behind the upper. Let's take a look at his iTero scan. For entrapment, we're looking for some sign of parafunction in the anterior teeth, either wear. I wouldn't call this wear. That tooth is obviously going to take quite a beating over the years where it's sitting up like that. Do we see any recession? I would say yes. So what is entrapment? When the lower jaw is in a position behind the maxilla, or better stated, the lower anterior teeth of the lower jaw are sitting trapped behind the upper anterior teeth. The muscles want the lower jaw to be forward, but the teeth are in the way. The teeth are interdigitating in a way that doesn't allow the mandible to drift forward, and the muscles over time cause damage of the front teeth. That's entrapment. A lot of times with menopausal females, we'll see TMD issues. It's not as common in men, but it can happen. This patient is a grinder, but if we look at his subjective reporting of his problems, he doesn't have any near earaches or neck pain, no clicking and popping, but he does clench. I bet that's more related to his airway issue. So is he entrapped? Possibly. Definitely something for us to keep in mind. If we look at his sagittal relationship, he is a little bit class 2, which would suggest that relationship. Well, let's see if he's class 2 on the left side. No, more class 1 on the left. Where this tooth is rotated, that cusp spent a lot of time receiving some lateral forces from the jaw. We love when the canine is guiding the jaw to the left, especially in a parafunction patient or a clenching and grinding patient, as he described himself. That tooth isn't designed for that kind of force. Something had to give, the bone around it gave. So not only is there recession here, but it looks like there might be more of a mucogingival defect also. So that's something we may want to probe. Very possible that as you probe, the attachment is going to be absent and you're going to end up probing into the mucosa. That's not a very stable periodontium. Let's see what else you had. So you had GERD and snoring. What does he want? Obviously, we can't send patients in a direction they don't want to go in. To have a nice and healthy smile with teeth that will last a lifetime. I would agree. So here were your strategies. Basic restorative. Essentially, that's just fixing what is wrong in a single tooth fashion. Looking at this here, there's a lot to do. Replacing all of the amalgams, giving him something to close these two spaces here. You'd probably end up, or he'd end up spending more than $5 to $6 grand. I would say build up, or we'll call that an onlay, composite, MOD, inlay, onlay, or crowns. On the lower, composite, crown, composite. So I would say 10 grand. I'd put like 8 to 13 here. And I like how you put disease removal. We want to give the patient some idea where they're heading. The pros and the cons well delineated here. Your second option, crown and bridge. Okay, I guess you did have that option there. I would just bump up those prices by $3,000. Then you had your comprehensive case, which is your phase plan here. And then you had all on 4. As we talk about, we always want to put something at the bottom that gives the patient a frame or a reference. We can call it bait. We're playing psychology with the patients each and every day, and the reason is we're trying to get them to choose what's best for them. They can't make those decisions on their own. So by putting this here, psychology indicates that the patient will more likely choose an option that's not, 1, the most expensive, and 2, the one at the bottom or top of a list if one of those coincide with the most expensive. The book Predictably Irrational by Dan Ariely is where I got this concept, and the moment I started doing it, I started getting more comprehensive cases. Am I tricking patients? No, I've changed a lot more lives than I did before. I like your style. So the phase plan, disease removal, put out the fires, love that term. Extract number 25. What's going on with 25? Yeah. I would endo test the teeth next to it just to make sure that you're getting a sense of their vitality. I bet they're fine, especially 24, but 26 might have some issues. This will be something we're gonna have to plan out. If you put an implant in after you graft that, you probably will have much less bone than you thought. Let's take a quick look at the axial view. And this one view gives us a whole bunch of information that gives us some sort of insight on what the patient might be able to have. If we didn't have this technology, we'd be guessing. Then we get to the end and we tell the patient, oh, you need a ridge augmentation for $3,500. So there's really no bone there vertically. I often will take this line and put it at the top of the best bone, and then I look over here and I say, if that's the top of the implant, what kind of crown to root ratio am I going to have? Well, implants do fine with crown to root or crown to implant ratios much larger than natural teeth. That's been studied quite a bit, especially if you control the occlusion. But to me, it's more of a cleansability issue. You could imagine the head of the implant being down here. The platform is going to be very far away from where the patient might clean. As we could see in his photos, he has tartar buildup everywhere. So this might not be a site for an implant. So I would prep the patient for that. I would talk about a Maryland bridge, a conventional bridge, or my favorite, remove the adjacent teeth and do an implant-supported bridge. I know that sounds crazy, but if the patient wants something stable, that's sometimes the best long-term solution. Let's go back to the PAs. Yeah, I mean, these teeth are already compromised anyways, so something for us to consider. We can spend more time talking about that. We could do some, like 2 rounds of vertical ridge augmentation, which might give us 3, 4, 5 millimeters of additional vertical height. But something to prepare the patient for, and then you talk about ortho, straightening everything out. So I would say the comprehensive case would be ortho. Let's just say 1 implant for the heck of it, root canal, and then this upper right area. You had mentioned what my thoughts were on that. That's pretty easy. We would slide everything this way, open up this space for an implant. Handling the roots here might require us to get some help from the orthodontist to get some root tilt. Invisalign does okay, but not that much. So that's what I would do. I would open up that space and put an implant in. You could probably just do it by crowning this tooth and getting an implant in. But I bet if we did some Invisalign in this area, we'd create perfect amount of space. I have a patient, D. McClure, in the shared drive. I did something very similar to this. So take a look at that. All right, I'm out of time, but great case. I would say $18,500 for the total cost.